this enlightening session of our 11th anniversary celebration at Docplexus. I'm Dr. Shitil, your host for today. Uh, Today's webinar titled The Fine Art and Science of Managing Ophthalmic Trauma Passionately. It's my utmost privilege to introduce our distinguished speaker, Dr. S. Natarajan, a name synonymous with excellence in the field of ophthalmology. Dr. Natarajan is a Padma Shri awardee recognized for his outstanding contribution in the medical field. He serves as the Chief Clinical Service and Chief Vitreoretinal Services at Aditya Jyoth Eye Hospital, a unit of Dr. Agarwal's Eye Hospital in Mumbai. With over 35 years of unparalleled experience, Dr. Natarajan is a pioneer in vitreoretinal surgery, having performed over 60,000 exclusive vitreous and retinal surgeries, including the first ever completely sutureless buckling. He has been the president of International Ocular Trauma Society and the chairman of the International Committee for the All India Ophthalmology Society. In addition to his surgical expertise, he has over 300 publications in esteemed national and international journals and has delivered over 2,500 presentations at prestigious conferences worldwide. His innovative spirit, coupled with his dedication to mentoring, has shaped over 68 vitreoretinal surgeons across the globe. He also has a Guinness World Record with a maximum number of diabetic eye screening, which is 649 diabetes patients were screened in Dharavi, Mumbai in 8 hours in the year 2019. Today, Dr. Natarajan will take us on an insightful journey into the intricate world of ophthalmic trauma management, a field he has not only mastered but also passionately elevated to new heights. So, without further ado, please join me in welcoming Dr. Natarajan. Over to you, sir.
Hello, greetings from Mumbai. Thank you, Dr. Shitil, and heartiest congratulations for the 11th anniversary of Docplexus. And I'm very happy. Docplexus is doing a wonderful continuing medical education program for all specialties in allopathy medicine. And, and thankful for the viewers and also the future viewers of the YouTube. My passion is ophthalmology. In ophthalmology, I do vitreoretinal surgery, and in that, I do the managing trauma. So now, heading various trauma societies in the world, including the International Council of Ophthalmology, I would like to talk on the fine art and science of managing ophthalmic trauma passionately. But before this, I would like to appeal to everybody to prevent eye injuries because ophthalmologists are busy tackling diseases, and now in addition we are doing one of the another highest cause of blindness of trauma. So the main thing is ocular trauma can vary from mild injuries that only requires topical antibiotics to vision-threatening trauma. So it not only if it involves the eyeball, it is ocular trauma. If it involves the whole orbit, it will be an ophthalmic trauma. That means, so that's why now the trauma societies are called ophthalmic trauma societies. And one of the common cause of unilateral blindness is trauma, which is in few millions in the world, which also account for bilateral blindness of more than 1 million people around the world, which is not a good statistics to have. Many things are preventable in trauma. Mostly, maybe 90% are preventable, except even in accident, I think if you have protective goggles, there is a possibility you can prevent eye trauma. And in ophthalmic trauma has been divided into open globe, closed globe, and both type of injury may be needed vitreoretinal surgery. And this is one of the terminology system called Birmingham eye trauma, and then later Ferenc School modified it, and then we have now eye gates, a part of the Asia Pacific ophthalmic trauma to get all the details of the trauma happening in the world. So you can see the classification having the you can see the cross section of sclera, cornea, and limbus, and zone 1, zone 2, and zone 3. Injury to cornea or limbus is zone 1, zone 2 is injury to anterior 5 millimeter of sclera, and zone 3 is full thickness injury more than 5 millimeter posterior to limbus. And these things are required so that they can calculate ophthalmic trauma score to know the prognosis. But however bad the prognosis, I think we should do a good surgery as though the eye is going to be restored as well as vision. So extreme trauma can produce corneal edema, hyphema, cataract, vitreous hemorrhage, commercial retinal detachment associated with subretinal hemorrhage. So a detailed history is important, and even in the clinic, I spend a lot of time with the patient. Apart from my optometrist, my counselors checking the patient, I need to know the mechanism of injury, whether a blunt or a sharp object causing. So I tell the residents and the interns to do a line diagram to see how the injury is happening, and also if you can know the velocity and size of the object and the material of the intraocular foreign body, it will help in preoperative planning. And visual acuity checking is very important, one for the patient himself or a kid for the parents, and also medical legally. So checking intraocular pressure is usually avoided because if there's an open wound injury, you can expel the contents, and you can have the injury. You can see here the trauma happened in the iris, and there is a traumatic cataract. And you should not put pressure on the globe if there's an injury, and you also have to evaluate whether there's infection, endophthalmitis, so we can plan vitrectomy. So we need to do investigation after we examine the patient thoroughly using the slit lamp biomicroscope externally, and also using ultrasound biomicroscopy, pain X-ray, CT scan, MRI in indicated cases, and electrophysiological cases in extreme cases. So we need to have a strategy in managing ophthalmic trauma, and the systematic approach must have its basis in the scientific literature and genuine personal experience, and no dogma should be involved. And I fully agree with Ferenc Kuhn, who was the president of International Society of Ocular Trauma and also now the chairman, that surgeon must not act on a trial and error basis, but according to this plan. And single stage versus two stage, an open eye glove should be repaired within 24 hours. And I recommend as soon as the injury happens, you should immediately do the surgery. That many times not possible. That's why they mentioned 24 hours. But ideally, if there's an intraocular body, you should remove it at the time of the primary surgery, but do the surgery with the goal of having a watertight closure of all wounds, and that will allow to complete a secondary vitrectomy if required. Many eye injuries require secondary intervention, and that's where myself and the Ferenc Kuhn propagate that we should do within 6 days, not as they written in the slide, 7 to 14 days. The reason is the textbooks, the journals say 7 to 14 days, but we are now recommending do the immediate repair within immediately or within hours, and as the previous slide mentioned, within 24 hours, and send the patient to a secondary care, tertiary care center for the second surgery, but within 2 to 3 days, so that the patient can go by train, air, or a bus, depending on where they are located in India or elsewhere in the rest of the world. But if they reach a tertiary care center in 2 to 3 days, they can plan the second surgery by making sure the patient is not in blood thinner if it's an old patient, and plus the injury patient with a young child can be evaluated for general anesthesia, and also the corneal edema can come down, and reactionary hemorrhage also can come down. And there are comparison between single and double two-step, but as I said, first step should be to close the wound, and second step should be to restore the anatomy and a visual possible. So in case of frank suspected endophthalmitis, primary vitrectomy is required, and optimal timing will depend on each case. And this reference says immediate vitrectomy is operated for post-traumatic endophthalmitis or intraocular foreign body with high risk of infection. And the best timing of vitrectomy for severe mechanical ophthalmic trauma is 6 days, and not as mentioned earlier. So we have some interesting cases. The single stage surgery in case of post-traumatic endophthalmitis. This is a 6-year-old male patient with history of trauma with fireworks. So that is why me, as a past president of Ocular Trauma Society of India, we have a committee which I chair, where we want to ban or restrict the use of cracker, so that unnecessarily people need not undergo so much procedure to save the eye, as well as there's so much of cost, loss of income because of loss of work. And here you see the preoperative B scan on the left, and the postoperative B scan on the right after post-surgery. And this is the surgery. You can see there is a severe endophthalmitis, and you're entering the antechamber using a MVR blade and removing making a infusion line. Initially, we have taken sample, sent for PCR, culture, and everything we are doing through the anterior chamber, because we don't know whether the choroidal part is swollen. So we are now using viscoelastic to deepen the anterior chamber, remove the exudate from within the eye. So I think the infected eye like this should be operated immediately, and I'm now using the forceps to catch the membrane and then remove it from the surface of the eye, and also use the vitreous cutter and remove the exudative material. And you can see that we are clearly slowly entering from the back of the eye into the back, from the front of the eye to the back of the eye, and the entire eye is filled with purulent material. So you can see, if you are not operated, the eye will go in for panophthalmitis, and then finally you have to eviscerate. So any eye, you have to first prevent the eye from not going into panophthalmitis, and then do an immediate surgery so that we can clear as much as of debris, so that you have to make sure that the infusion line is within the vitreous cavity. And most of the eyes we can do using through the cornea, and I nowadays use 3D surgery so that you can have a wide angle observation. And at present I'm injecting air to have a better view so that the hemorrhage is not dispersed. So here, sorry, I just moved the slide. So and now we are completing the vitrectomy, and you can see under air I'm working on the, and then removed all the vitreous, and then left the eye with the air in the AC, and the posterior part with the oil, and then used a half dose silicone oil, so that half dose antibiotic intravitreally because of the silicone oil, and did a 6 o'clock iridectomy so that the eye can be saved anatomically. And most of the time the eye does well with the one procedure. But in case if there's an infection again, we can do a vitreous lavage, remove the oil, and re-inject oil if required, or use and then treat the eye with the repeated intravitreal antibiotics. And this eye was saved. And this is a pellet injury with a 34-year-old male who was present with a history of penetrating ocular trauma with a pellet trauma. B scan showed vitreous hemorrhage. CT showed retrobulbar metallic foreign body, and flash electroretrogram showed the right-sided marked diffuse reduction in photoreceptor function, and pattern ERG findings were suggestive of reduced function of right macular photoreceptors. So this is just an indication to tell the patient the visual prognosis is guarded, but still we can attempt. And this was the pre-op. The immediate corneal wound repair done, total cataract happened. That's the CT scan picture and the ultrasound. And the patient was operated on 8th September. My co-surgeon, Dr. Kavita Rao, did the cataract surgery. She did a phaco emulsification with the intraocular lens. And then following that, I made a 3-port pars plana vitrectomy and did the 3-port vitreous hemorrhage. So you can see the anterior segment is being managed, and then the intraocular lens is being introduced, and then I'm now introducing the cannula, and I'm removing the vitreous hemorrhage, and there is a submacular hemorrhage, and I use the viscous fluid extractor, and using a 39 gauge needle I do a drainage of the submacular hemorrhage so that the fovea and part of the macula is cleared, and then use PFCL to dislodge the blood clot, because it was just a this was so I dislodged the clot from away from the fovea, and then you can see the disc and macula clear. And then I did an endolaser around the brakes, and then also the retinotomy site, and then left the eye. So the patient actually improved, and the patient improved to counting finger 1 meter, and because of the corneal the irregular astigmatism, we can see the suture. One day the corneal astigmatism can be corrected, and once the retina is stable, the oil was removed, and then left the oil with the eye with the air, and then following that the vision improved to 6/60. And my experience with vitrectomy using temporary cataract process in traumatic endophthalmitis, you can see a 24-year-old male with a trauma, and 20 days later the patient was referred. That's why I repeatedly said they developed a severe corneal abscess, and now you'll see it is quite a challenging job of doing a vitrectomy. So we planned for a to open temporary cataract processes. Now that I'm requesting the corneal surgeon, Dr. Kavita Rao, to do the corneal, remove the corneal bottom, the infected corneal material, sent for histopathology partly, and partly for culture and sensitivity and PCR. And you can see necrotic material. So instead of using temporary cataract process, and I already put a flaring gas ring to prevent expulsive hemorrhage, using the vitreous cutter to clear the debris from the surface of the posterior segment. We really don't know whether what I'm removing, but the whole idea was to remove the necrotic material and the infectic material, maybe part of the some part of the intraocular tissue. We don't know what it is. So that's why part of it I sent for histopathology to know which part of the anatomy I'm cutting with the cutter, because there's a possibility sometimes retina may be there. But if you don't remove the infective material, the eye will go in for panophthalmitis, and there's no other go to save the life. You have to do evisceration. So in my experience of 40 years now, rarely I do evisceration and inoculation, provided the patient can come in time and does not have panophthalmitis. And now I'm dissecting the exudative material which is there on the surface of the eye and the iris. And now I've cleared the eye. You can see there is no infection now, and eye has some pre-retinal hemorrhage, some hemorrhage. And then I'm using my corneal surgeon is using the graft, and then you do the clear corneal graft. And sometimes this graft can become opaque, and we can do at present we have used a preserved cornea because they tend to get opaque. Later you can do optical keratoplasty using a clear cornea from the young patient. Post-operatively, the patient was having counting finger close to face. You can see there was a retinal detachment. The patient refused to undergo further surgery. But if the patient was ready, I would have done vitrectomy, PFCL, silicone oil. And this is a 40-year-old male with a history of assault by 8 people in some street fight with a bamboo stick. He had a nasal bleed, supraorbital laceration for which primary suturing was done elsewhere. And he had no light perception, lid ecchymosis, congenital congestion, and eye was collapsed with hyphema. So the CT scan showed a distorted globe. You can see the uveal prolapse happened and scleral tear. And then in the 2 hospitals he went, he was advised evisceration. Somehow, one of the taxi driver told him, "Well, let us try at the youth hospital." They came to me and they told me that can you save the eye as well as vision? So there was option of either evisceration or reconstruction. So I decided to reconstruct. You can see the various steps. It took about 3 to 4 hours for doing this wound repair, because open the eye itself was tough. And then I took 3 hours to repair, and then 15 days later, because we couldn't enter the eye within 6 days, because there was a severe lid edema, severe orbital edema, so it gave steroids, reduced it, took 15 days. And then what next? We planned for a 23 gauge vitrectomy, so I did a AC maintainer to do the infusion line, because we don't know, in spite of the ultrasound, there can be a suprachoroidal effusion happening. So now I make a 360 the 3-port pars plana entry using the 23 gauge trocar cannula system, and then do a vitreous lavage. So now we made a AC maintainer as an infusion, and then using the 2-port to enter the eye and clear the eye of the vitreous hemorrhage, and then clearing the media, and then go inside the eye and remove the periretinal hemorrhage, then use perfluorocarbon liquid to drain the subretinal fluid and suprachoroidal hemorrhage, which was already drained, and some subretinal hemorrhage was there. And you can see the retina attached. That's why you could do 360-degree laser, and then leave the eye with this is still, you can see the PFCL in the posterior part. So I'm doing a 6 o'clock iridectomy, and then I do a PFCL air exchange and then air oil exchange. The idea is to reattach the retina. So however bad the eye is, and then here I'm using the silicone oil injection and then removing the PFCL, and then leave the eye anterior part with the gas. So we could save the eye, but the patient developed PVR again. We did another surgery. So the eye is actually protected from direct injury by lids, eyelashes, and projecting margins of the orbit. That's why in evolution, when the animal had eye in the front, the eye was gone into the orbit. But nevertheless, it can be injured in various ways by chemicals, heat, radiation, and mechanical trauma. So it is the number one ocular emergency, which is the leading cause of blindness, irrespective of the age. Male and young age group is unfortunately affected more than the female. Efficient referral expected from the professional. So even from patient relative, I think they should refer the patient, even if they had a patient who had undergone wound repair and then the vision did not come. But still, any other patient, you should prevent injury. But nevertheless, if it happens, you should do a quick response. So we have to have a QRT, quick response team. And prophylactic measure is better than management. But nevertheless, if it happens, you should send the patient. This is a 76-year-old male who actually had an open globe injury. He did not want to put the light on, and he opened the he went to the toilet, but on the way he got injured with a sharp object. He doesn't know what. The sharp object went into the eye, in and out, and came. And we planned the surgery. And after the time, you can see the first surgery was done. So this was the first surgery where we tagged the muscle, and then we started doing the vitrectomy. And then what we did is I put a belt buckle around using the belt buckle, and then after that tied the and then did a vitrectomy. During vitrectomy, unfortunately, suprachoroidal hemorrhage is happening, and I thought in the beginning it's a suprachoroidal effusion, but by the time I could control using heavy oil and air and gas, luckily the hemorrhage could be stopped, but could not do further. So I removed the belt buckle and left the eye with air, and the intraocular pressure was high, and then put the remove and close the eye with the thing. So this was again, the eye took time to heal. It took 18 days. Then we did a silicone oil removal, and you can see we did a vitreous lavage, and then we saw after removing the blood there was a total retinal detachment, and there was a heavy oil behind the retina. So any eye, I don't give up until the patient gives up. But the idea is to counsel the patient a lot. You can see a large retinal tear, and I'm going through the subretinal space, and then I remove the subretinal silicone oil using the viscous fluid extractor, and there is a macular hole seen. Through the macular hole, I do endo drainage, and then I do a endo drainage, fluid air exchange. Under air, I reattach the retina, and then use air oil exchange. So immediate post-operatively, you can see the laser was done around the macular hole and the retina was attached, and the patient got 3/60. But unfortunately, developed recurrent PVR. I did resurgery and got back about 1 meter vision. But this is a problem with when the macula is involved and there's total retinal detachment. But nevertheless, even to get that counting finger, we should do the surgery because the other eye was normal today, but he's 76. He may live up to 100 or 100 years plus. In case he gets another injury or any other problem, this eye can act as a stepney. And this is an eye with a pellet ocular injury, which I did in Kashmir. So this we made a special incision. We have designed myself, Dr. Manish Bapai, and Maya Sharma designed special forceps to grasp the pellet from within the vitreous hemorrhage and remove it through the 11:1 incision. This is our contribution, a new surgical technique, as well as a new instrument, and then close the scleral wound, remove the intraocular foreign body, and or any irregular foreign body, and then continue the vitrectomy, remove all the vitreous, and then you see a subretinal hemorrhage and the exit wound, and do a laser around the exit wound as treat as a coloboma choroid, and then you can see the retina is attached well all around, and this patient can underwent a secondary intraocular lens 3 months later, and then the vision improved to 6/9 and 6 because of the disc and macula was on, and was a young patient. So this is a and this is a 24-year-old trauma, which we already saw, and post-operatively. So this is a pre-op with no PL, and the vision came to counting finger. And because of the only in trauma with no PL, we can do surgery. And this is another patient with a pellet removal, where it's a previous one was a phakic eye, and this is a phakic eye. So you can see all young people in phakic eye. You can you do the vitreous hemorrhage clearance, and then make a 11:1 incision, identify the foreign body, and grasp the foreign body using the this new forceps which we have created, and we make 11 o'clock to 1 o'clock incision in the sclera and grasp the foreign body and remove it, and then continue the residual vitrectomy, and then close the scleral wound, and then complete the vitrectomy. And if since the patient is phakic, the patient can get good visual recovery. So pellet, there are 1,011 patients underwent pellet ocular trauma, and we operated about 800 patients along with Dr. Tariq Qureshi, head of the department. So the vitrectomy will be depending on which type of patient, and then in an end ophthalmitis, clearing of media is important, and vitreous sampling is important. So as I mentioned, many times we use the AC maintainer, or you have to use a long cannula so that you clear the eye. And this was a pre-op, and we can use a portable single entry. It is called an Intector, designed by my friend Frank Koch from Germany. So this is a single port. you can infuse the eye, and also there's a sharp end of this cutter, and it's a battery operated cutter where you can enter the eye, remove the vitreous, and also inject the intravitreal antibiotic, so that with one port we can manage and use because there's no endoilluminator, use the microscope light, and using the contact lens now remove the debris and give the intravitreal injection. We can also use 27 gauge depending on the, so that the size matters, because smaller the entry, the healing is better. And you can see this is again a traumatic patient with a and then developed traumatic cataract and suprachoroidal hemorrhage. So you are clearing the traumatic cataract and then using the AC maintainer and removing through the another the entry chamber. The reason is we don't want to enter the eye through pars plana unless we make sure the pars we can have a clear entry into the pars plana. So I'm now going through the wound, which is not generally recommended, clearing the pars plana region, and then entering through the two-port pars plana vitrectomy and having the AC maintainer and clearing the vitreous hemorrhage. Then we saw there was a total detachment, there was no PVD, induced PVD, removed the blood clot, drained the subretinal fluid, and then used PFCL again to drain the subretinal fluid. And under PFCL, air oil exchange was done, and then air oil exchange was finally completed. And you can see the patient had a disc pale but attached retina with a silicone oil, and we removed the oil about 6 months later. Patient maintained 624 vision. And this is another eye. Is a sick patient, SIKH. We call them Sardarji, where he was using a sharp needle to tuck his turban, and then unfortunately poked an eye which underwent penetrative keratoplasty. So we usually wait for a week to 10 days for the blood to clot. We gave steroid, but in spite of that, after making a sclerotomy, you can see the blood clot is very thick and it's coming slowly. But I made multiple sclerotomies, and I did a vitrectomy. We can see the suprachoroidal hemorrhage. I used PFCL and then had a scleral wound so that the suprachoroidal hemorrhage can be drained externally. I did that alternatively. You can see the amount of altered blood coming out, and it is still semi-clotted, and the idea was to remove and reattach the retina. It took a lot of time. Now this is a posterior sclerotomy. Nowadays I don't do sclerotomy. I make a trocar and then I do it. And you can see I am now continuously doing multiple PFCL injection and draining the suprachoroidal hemorrhage and maintaining the keratoplasty done eye. But we could drain 90% of the suprachoroidal hemorrhage, left the eye with heavy oil, so the heavy oil does not come near the cornea. And this we already saw trauma, palate-ocular injury, and then this is another palate-ocular trauma patient where we did a removal of the foreign body, and you can see this is the intraocular foreign body removed. And then this is the eye with a peripheral, the wound repair done. You saw the corneal suture. We did a lensectomy and vitrectomy with the patient had a traumatic cataract with vitreous hemorrhage and subretinal hemorrhage. So the reason we did was that there was a foreign body also seen, which we located and used the foreign body forceps to remove it, clear the subretinal, the vitreous hemorrhage, and located the foreign body, removed the foreign body, and you can see the subretinal hemorrhage inferiorly. So we did a barricade laser around the subretinal hemorrhage, and then left the eye with gas. And then after that, the subretinal hemorrhage drained because it was away from the macula and disc. We left it as it is. And this is a 34-year-old male presented with closed funnel retinal detachment with suprachoroidal hemorrhage following road traffic accident. And the hospital said, we have done the first surgery, but now it's better. Even if you operate, it's better. Vision may not come, so no point in operating. Still, you want to try, you can go to Dr. Natarajan or All India Institute in Delhi. And the patient came to me, and this is what you can see. So I'm now using the PFCL, but you can see the temporal retina was totally torn, giant retinal tear, and then the entire retina is crowded like a force, and then I'm using a chandelier eliminating the vitreous cavity, doing biomanual surgery using two forceps, opening the flower, and then use perfluorocarbon liquid and reattach the retina. So what looked inoperable is now we can see the retina is totally attached. Using the retinal brush to separate the fold, and now I'm doing under the perfluorocarbon liquid the endo laser, and then replace the PFCL with the silicone oil, and then you save the eye. But the patient developed recurrent PVR, and after that again I did one more surgery, and the retina was attached. The patient got about 1 meter vision. He was a young patient, but the other eye was all right. That was the picture you saw. You can see the pre-op picture with the vitreous hemorrhage with total detachment, and the post-op corneal sutures were removed about 3 months later, and then did a secondary intraocular lens with an also artificial iris by my colleague. And this is a 63-year-old male with complaint of letter redness following injury after a leg slipped off and fell, and then developed this problem. And you can see there was a total retinal detachment, and you can see the we are doing we did a like the we are now entering the antechamber because I decided we can do a cataract extraction with the lens implant by the Dr. Anupam Deshpande, and then I can do the posterior segment. Now he's entering the he already placed the intraocular lens, and I'm using the 25 gauge vitrectomy, 3-port pars plana vitrectomy, and completing all the vitrectomy, and saw the total retinal detachment. And you can see there's a total retinal fold extending from the optic disc to the periphery, and then I'm now using the PFCL and releasing the fold, and then you can see I'm using the retinal brush, and there are multiple breaks seen, and then I'm removing all the membranes and now separating using the retinal brush. It's a patient surgery all the time. It's a back breaking surgery, so as a vitreoretinal surgeon you need to do back exercise. The protagonist muscle, antagonist muscle should be strong, and make sure, and then reattach the retina. And then I have a good operating chair. I call it Maharaja chair to make sure that my back is supported, elbow is supported, now separated the fold, and you can see the retina. I'm now using the perfluorocarbon liquid, separating the fluid and reattaching the retina, and then UPF seal is exchanged with the oil, and laser is done around the break, and now you can see PFCL air exchange done and air oil exchange is being done. So under the oil, we have taken a photograph, and you can see this is a picture post surgery, and the retinectomy done is a laser has been done. Then only we could separate the fold and have the attached retina. And this is a 70-year-old male with a road traffic accident. You can see severe trauma, and then you will be seeing now that it's really a bloody surgery. There is a blood everywhere, subconjunctival, in the aqueous humor, vitreous hemorrhage, so, and suprachoroidal space. So it will be looking terrible, and the only thing is you have to reassure the patient that you will do the best surgery, but you can't promise result. But in your mind, you have to have the result in mind and do the best surgery. And I always remember a thing that when a patient is semi-conscious and he tells the doctor, operate on me as though I'm living, don't operate on me as though I'm dead. Same thing here. The eye is telling, looks like I'm gone, but please operate on me as though I will get restore my the eyeball and also restore the vision. So this is what we are doing, removing the blood, removing the blood from all in the eye, outside the eye, around the blood, and then reeve the eye with the silicone oil. And so you can see this is a patient with a attached retina, but there are multiple membranes again contracting. The patient had a hand motion close to face. We did another surgery, retinectomy, removed all the membranes and reattached the retina. There is a risk of PVR. That's why we have to do research to stop this scar tissue formation, which is what we need. A lot of funds to do research. Methotrexate is being tried, but the problem is you have to give intravitreal injection almost every week for about 14 weeks. And this is a 34-year-old male with a blunt injury during argument. So the best way to prevent is just accept the argument, don't get into fight. But if you have a fight, you can see the patient had orbital fracture, and then I'm doing the 3-port pars plana vitrectomy, and then you can see blood everywhere, and then I'm removing the blood and see total retinal detachment. Under air, I am now separating the folded retina and using PFCL oil to reattach the retina. And so this meticulous surgery needs to be done, back breaking surgery, but make the back strong so that it cannot break your back, so that you don't become an orthopedic patient. That is occupational hazard. But you can definitely fight with the problem, do the best for the patient. So 3D surgery really helps, and the ergonomic. And this is a post-operative picture. And this is a 52-year-old male with a trauma. Again, you can see how the pre-op picture, the terribly soft eye with a, and then you can see the this is the eye where you can see I'm entering again 3-port pars plana vitrectomy, and you can see under the inside the eye there is a scar tissue, and because it's already operated, there's a silicone oil is there under the oil. I'm now using the forceps and removing the membrane. So I stained the eye with a brilliant blue and removing the internal limiting membrane so that the scaffold will be removed, and I'm trying to separate the fold and separating and reattaching the retina. So the periphery you can see retinal break, and I'm using the retinal brush to tease all the membrane, and then I'm also making a retinectomy so that that part can be release the traction so that the disc and macula and the rest of the retina can be all right. So you can see endo laser has been done, and then again remove the PFCL oil has been injected. So I am showing extreme trauma where many times many surgeons will give up, but I don't give up. And now we also made a foundation called Kamala Sundaram Foundation in my parents' name, and Sundaram Natarajan Blind for India Foundation, a Section 8 company to help people who cannot afford. Hence, I also become a emeritus professor of ophthalmology in Lokmanya Tilak Medical College, SAN, and also emeritus professor in Tamil Nadu MGR University, and also the Marmonoid University, Argentina, and in Ramchandra Medical College, Chennai. And I travel world over to teach and show all these videos. The idea is not to show off. An idea, you see, you can see the eye which was torn, the scar tissue in the periphery, retina is attached, and the disc and macula is okay. Patient got about 3-meter vision. The vision may not be normal. Even in the palate ocular trauma, 80% got only counting finger vision. But all of them will bless me, because in case the other eye is affected in some time in life, this half-meter vision, they can see their plate, eat, they can go to the toilet, and then they will bless me. And then because of that blessing, I can do more surgery better. This is a 13-year male with a history of a road traffic accident where a four-wheeler is a four-wheeler driver dashed to a tractor, and then this problem happened. So you can see this is the patient. You can see the I'm tagging the muscle, and this is to check the because where the injury has happened, we don't know whether anything is there in the suprachoroidal space or external. So that's why, I mean, you can see we found the outside wound. We are suturing it, and then internally also we are checking, and then now closing the conjunctiva. So the idea was that they repair the eye externally and also internally. So he left the eye in the front part with the air. So this is a temporary character process. You can see this is the so I use a temporary character processes, and you can see this cornea was necrotic, and the exudates are like something like a phlegm inside the eye. I'm using the corneal forceps and then using the scissors to remove the exudates from the within the eye. And then my corneal surgeon said the cornea is necrotic. I don't know whether the cornea will hold. You're wasting a cornea. I said no, you're saving an eye. So this is where the preserved cornea will help. And later, if the eye is surviving, we can do a penetrating keratoplasty, I told. But you will be seeing that after completing the vitrectomy, after doing the keratoplasty, you will be seeing an astonishing retina in the back, because we thought we did ultrasound. The ultrasound showed attached retina. There was a vitreous hemorrhage, but there was incomplete PVD. But we were also having a suspicion. Sometimes the ultrasound, in spite of doing, may be showing that there is a vitreous hemorrhage with retinal detachment or a X-rays with retinal detachment. After flying a ring, my corneal surgeon put the Eckhart's keratoprosthesis, did airtight, watertight suturing, and then used the 20 kg infusion I used. So that means this video is taken almost 30 years back, but we saved the eye. And you can imagine if you remove the eye, how the patient will feel. And now this is a view through the keratoprosthesis processes, and you can see that I'll be removing the exudates. And this is, as I said, because it was a 20 gauge and 30 gauge instrument used 30 years back. So I'm happy my team has maintained it. Thanks to all the IT heads who are maintaining my videos, which I'm operating. So I'm operating trauma patients for the last 40 years or 42 years, 2 years during my postgraduate in Government Eye Hospital, Madras, and then 40 years from Shankar Nethralaya time to Bombay Hospital to Aditya Jyoti Hospital now, and partly in Hinduja. And I also do live surgery to demonstrate repair of the eyes world over. The reason is to teach them that don't give up. You can see the X-rays are being cleared the way after the PVD is induced, and then making sure that slowly I'm doing the vitreous removal, the exudates, to make sure that there's no underlying retinal detachment. And then slowly I'm exposing the retina, and then to my surprise, I find a healthy retina behind, even though there was a thick exudate. So the idea is kindly refer the patient to any vitreoretinal surgeon in 2 to 3 days. I said, let the vitreoretinal surgeon take the responsibility and manage the patient. Let him decide if he can operate within 6 days, if not possible, as early as possible, so that he can save the eye and save the globe, the anatomy, and also restore some vision. And why not try to get the best vision? That's what is my topic. Why not we repair the eye passionately, like me, so that every eye can be saved? Now, passionately, I want to impose the lot of advocacy to the government, to the public, so that we can prevent injuries either from cracker or during holy throwing balloon or while playing street cricket or tennis or anything, where if you don't have protective gear or a protective goggles, and you should have a protective goggle which is US certified or Canada certificate, because we need that, because the glass should not break. We had a child who had a glass broke and cut the eye, and you can see now the optic disc is clear, retina is so clear, and you can put the corneal button and do the corneal suturing. And this patient, there's a possibility, because the eye is good, you can also get 6/9 vision after a secondary intraocular lens. But this eye, we left it aphakic for long because it was 30 years back, and now we will do that. So my philosophy is, even if the eyes after injury has no perception of light, should undergo a primary repair, even if you expect the anatomical success is estimated to be less than 1%. That means never give up. So I remember my another mentor, Dr. Jovanovic, who operated a lot of war injury patients in the 80s and 90s in Rotterdam and Antwerp, and he retired. So he taught me this skill. Now we have got a foundation in his name called Jovanovic Foundation, thanks to Mr. Ger Feinfinkel and also Dr. Grazia Pertile from Verona, Italy, where we made a foundation. We want to give 15,000 euro a year for a doctor who has been done vitreoretinal surgery and wants to specialize in doing complicated retinal surgery for trauma patients. So they can go to 3 months to 6 months to observe with Dr. Grazia Pertile in Verona, Italy, and come to me for doing practical surgery under me by getting the temporary license from the National Medical Commission of India, Delhi, and then work with me and do the best repair for injury anywhere in the world. I'm happy. I would train doctors from all the 6 continents, and there are 2 or 3 waiting from South America, Europe to come to India now. So this is again a 25-year-old gentleman, and you can see this is the vitreous hemorrhage where we are doing a vitrectomy, and you can see after clearing the vitreous hemorrhage, we can see the intraocular foreign body being grasped, and I don't like the pellet to fall on the surface of the eye, and I actually grasp the foreign body and then remove it. So that's why there's a 4-prong forceps designed by Manish Papaye. My Shenmue, my soul is very useful, and it can catch any irregular stone, glass. So that's a beautiful instrument. And after that, complete the further vitrectomy. And in this eye, you can see the vitreous hemorrhage is cleared and the retina is attached. And then wherever the exit wound is there, we left it like that, and then did a endolaser around it. And this is the counting finger 1 meter liter. And this is another eye where you can see that a glass foreign body was grasped, stuck in the antechamber, and I'm using the forceps through the region of the grasp and remove the So I don't know why the movie is not working, but here you remove the foreign body through a large pars plana incision, and then close the wound and check the periphery to make sure all right. This is again a video taken 32 years back, and you can see the Aditya symbol also was different. And here
Management of unusual
this is my
intraocular
voice
foreign
in
bodies. In
1992.
India,
So you can see that the unusual intraocular foreign body, where you see a thorn which penetrated and injected the infective material in the eye, and you can see that exudates are within the eye. And then I do a three-port pars plana vitrectomy, clear the eye. And at those days we used contact lens to remove the vitreous exudate, and you can see the retina details well. And this patient did well. This is another patient where thorn had entered the eye, and 2 months later he came to me, and now I'm clearing the vitreous hemorrhage and then grasping the foreign body. It is a 13 millimeter thorn which was there inside the eye, and you can see I'm using the vitreous forceps to clear and now I'm grasping the foreign body which is there in the pars plana region, and I dissect it from the pars plana region and then clear. You can see now I'm using the diamond studded Macamar forceps to hold the foreign body and make sure it does not touch any of the inside of the eye. And I make a corneal incision, coat the posterior surface of the eye with the viscoelastic, and then you have to be ambidextrous. Infusion lines going on, and I'm using holding the foreign body with the right hand, and with the left hand I'm using the blade to cut the corneal make the corneal incision, and then remove the thorn using an anter-segment forceps. So it's a Herculean task and a very complicated surgery, but you can save many eyes. Never give up. So do a meticulous surgery. For that you should get a very good training. Now we have simulators, we have pig's eyes, we have the enucleated eyes which cannot be used for keratoplasty, and we can. And my dream is to set up a training center for that, so that we don't have to practice in the doing surgery. We can train them in the eye, like the pilots are being trained using the simulator. They can use the goat's eye to practice all these injuries. And now we can also use a bionic eyes, which is artificial eye, where you can induce a foreign body inside and then remove it, so that you don't get a surprise when you're operating. So to reiterate my philosophy, if an injury happens, please do the repair immediately by an excellent eye doctor with microscope, and refer to a vitreoretinal surgeon in 2 to 3 days anywhere in India. All the states and union territories have vitreoretinal surgeon, and I'm sure every young doctor who's well trained in microsurgery can handle them. So please do well, and whoever wants to send to us, we are ready to support, even if they don't have money. So thank you very much for a patient listening. And now Dr. Shitil can open for questions, and I'm happy to give this talk. I know.
Thank you so much, Dr. Natarajan, for that wonderful presentation. We have a few questions from the audience, so let us move on to the questions now.
Yes.
So, my first question to you is, what are the immediate steps a doctor should take when faced with a patient presenting with an ocular injury to prevent further complications?
Yeah, one is to counsel the patient, and also explain so well that the patient needs surgery and there's a risk of infection happening, as well as the vision may not come. But the way you tell is important, because there can be aggressive patients if it is a part of a mob fight. So we need counseling. Better to doctor should have a good support. And in case he's in a town where there are senior surgeons, if he's a young doctor and senior surgeons are available, either he calls the doctor here, or the patient is referred immediately, and whatever it is, explained to the referral doctor so that they receive well. For example, a junior doctor referring to a busy doctor, you have to make sure that the team, the nurse, the counseling team, the outpatient manager, everybody gives a. So in our hospital, we have code O, that means code ophthalmic emergency. We call code orange. We are given that code. The reason is, Any injury in the eye is an emergency, maybe a simple injury, complicated, we don't know what it is. So that the doctor should talk to the people so that the patients are not made routinely. And many times I see the patient wants, like for example, they talk to me, they say, I want an appointment. And they should not ask for me or appointment. They should ask for a good eye doctor, so that if I'm there, I will do. If I'm not there, like that in any clinic, a senior doctor is not there, somebody who's well trained should be there, and the patient should know. And that's why these sort of things the public also should see in YouTube. I know it's looking gory, but the idea was to say the injuries are gory, and it happens to a common man, and there's also common man have to see this. And if it happens to him or any relative or anybody, they should refer immediately. And the eye doctor also should take all precaution medico legally and also compassionately. That means I always tell this to my staff as a part of staff training, the difference between sympathy, empathy, and compassion. So nobody should sympathize, they should empathize. That means if you are having a passion, and if you are doing you feel that pain, which is what I want my nurse and my OPD reception to do. So I am trying to do a lot of things in my website and do publicly. And I request through this the doctors, even if it's a general doctor or even a specialist, I mean, if something happens, do go to the immediate and make sure you alarm everybody involved that there's an injury and it's like a fire in the building. So please make sure, give way for this patient, and every other patient should adjust and get the treatment done immediately.
Thank you for answering that. Moving on to the next question now. So my next question to you is, in patients with underlying diabetic eye conditions, how does trauma management differ, and what additional precautions should be taken?
So in a diabetic patient, one is immediate, definitely control of sugar. So actually, not only in any patient you should do immediately. After doing this recommendation, there was a child who came as a follow-up yesterday, about 9 months back. He had an injury, and the whole he had actually injury. What happened? He bought this Swiss knife, and without telling his mother, he saved money, his own money only. But without telling the mother, he took the money and bought the Swiss knife. Went to the tuition class, and then when he was opening the knife, somebody from behind came and pushed. So the Swiss knife went in and came, and part of the eye parts came in his own hand. So he took it in the handkerchief, crying, and then he was feeling guilty that he didn't tell his mother, and he got his eye injured. He became blind in that eye. And then they went to a big hospital. I don't want to name the hospital in Mumbai. And they were admitted. And then the eye doctor said, the part of the eye is there in the bottle. So now no point in repairing. We'll remove the eye. But the only thing was the eye was swollen so much like a tomato outside the eye. So the doctor could not even open the eye. So they did a CT scan and found the eye was totally collapsed. And then somehow the patient contacted the MLA. I can tell the name, Mr. Sanjeev Rawat, and he contacted the trustee in Siddhivinayak temple called Mr. Sanjay Savan, and he called me and said there's an injury. So I told, send the patient, send the CT, everything they sent. I was in Malaysia, and I told them, I think we have to examine immediately. Can you ask the patient to come to Aditya Jyot, so that my associate, one of them, will see. And that day, Dr. Smith was on call. He was ready. These were around 4 o'clock in the evening. But injury happened 2 days before. And the patient was admitted for treatment because the eye could not be opened. Even though I said wound repair has to be done. Then the patient, when they told the doctor that they want to go to Ayurveda, the doctor refused. If you want to go, you take against medical advice and go. But then the patient requested, okay, sir, can we get the Aditya doctor here? He said, no problem. So we gave a special letter. He took the permission, and by the time all the authorities gave permission, doctor, it was 9 o'clock in the night. My Dr. Smith, who's a consultant with me, who's available 24/7, he went, examined the patient, did a live video for me. So we do this now. We do a video call between the doctors, consultants, so that patient explaining to me is a problem, because they will one emotional, they can't tell the correct thing. So the doctor explained to me, and when I saw the eye, I said, we can't do immediate surgery because you can't even open the eye. So how do we do surgery? So I told, give steroid. By the time I'll come, I will do. But surprisingly, the doctor who was treating him said, I know I have 20 years experience, you can't do anything, so I'm not discharging the patient. He said, if the patient wants, they can go against medical advice. I was very surprised. And anyhow, I told the patient, you take against medical advice. You tell the patient, I take responsibility for, and the patient had trust. They came. It took to another 2-3 days to the blood to resolve, the swelling to go. And to my surprise, I could repair the eye 100% successfully. Repair only, but I could not restore the sight. But I did another surgery because the patient had a very bad. Because of the eye went in and out, the part of the retina had already out, and it is like a crushed tomato. So same thing. We had a patient with the diabetes. Correctly, you asked me. Both are having the same surname. I don't want to tell the name of the patient. And this patient was from Bombay. That patient came to the clinic today for some other thing, and he's going to see me tomorrow. And that patient also a diabetic, and he was his brother is the hotel association president of UP. So he contacted the hotel association of president in Chennai. He knew another doctor, my colleague, senior doctor, who was 80 years old in Kanjipuram. He called me. Then I told, okay, send the patient. But because the patient, you know what happened? The patient was admitted under the eye hospital for removal of the eye, and they could not remove the eye because of diabetes was not under control, and back it was something like 600. So because by the time they contacted me, I said nothing doing. Control the sugar, but they send the patient here. I will see the eye, I will repair, and no need for removal, because there is a eye which I didn't talk in this talk in my topic. There is a condition called sympathetic ophthalmia. If one eye is injured and if the uveal prolapse has happened in before 1980, every doctor was removing the eye. If the injury happened and then in 2 weeks they didn't report, within 2 weeks if they can't repair, they removed the eye, because if they don't remove, they will get sympathetic ophthalmia. That was the theory. Even though it can happen, but now we know that the uveal tissue is repaired properly, and you use steroid, plus you treat if there's infection, and even if the patient develops sympathetic ophthalmia, diagnose immediately and treat with the methotrexate, that is the anti-cancer drugs, antimitotic drug, you can save the patient's eye. That means meticulous care. Patient also has to go for small complaint. See, nowadays is a very bad thing happening. The patient will send a WhatsApp and say, okay, what can I put drops? And redness is there. That one particular thorn injury I showed, the patient didn't even realize after he fell down, the thorn went in the eye. He went and told the doctor, eye has become red, I fell down. He didn't tell that something has gone in the eye. And doctor also could not see, because ultrasound, that X-rays were messed with the iris and the choroid and pars plana. So the ultrasound did not pick up. And finally, the patient was treated as the uveitis for 2 months. Finally, I removed. So what I'm saying, nobody should treat in WhatsApp. That's why I call this as a WhatsApp syndrome. Stupidity. I really hate it, because how can, I mean, even now somebody asked me some other surgery, even cataract surgery, how can they'll send a report and say, can I put this lens? So I think as a diabetic, even today, some other patient I'm operating, patient has got diabetes, renal problem, then cardiac pacemaker has been done, and he's a big man. So their patient is asking me, why do X-ray? Why do this? That is where they have to have a trust with a doctor like me. I agree. There are problems. Five fingers are not same. Five doctors are not good. All doctors are not bad. So that is where you have to go to you have to have time to think and go to a good doctor. So that is why when the things are normal, you should know if you have a heart attack, where to go. If there is a fire, how to call a fire engine. If there is a heart attack, a cardiac arrest, how do we call the cardiac ambulance? Everything should be known in a house. And same thing, if there's an eye injury, what to do? So we can't be going to every house and telling and putting TV, even though I want to do that. But so as a good question, if injury happens to a kid or a cancer patient or a diabetic patient, you have to take care of that primary thing, because life is important. Just because sugar is 600 and I told we have to operate the eye, you cannot take the patient and kill him, no, or he dies doing the surgery. Or if he's in a blood thinner, he'll bleed more. So those patients have to take the risk of waiting for the eye. But have to, if you don't wait, you'll have a risk for life. So this is where cardiologist, diabetologist, nephrologist have to have a discussion before operating. Now this patient, I'm doing all this. We do a Zoom meeting, and this one child I operated, they developed a complication after the first surgery. What was the complication? Anesthesia complication. So the father came to me crying, "Sir, my child went walking, and in the 2-3 hours later, the child came in the stretcher, unconscious with the tube in, and the patient had pulmonary edema. You know, they saved the child. That can happen. So, next patient, next surgery, Patients' parents were affordable. They contacted some 10 different doctors. So we sent to pediatric cardiologist, pediatric intensivist, pediatric ICU, NICU, like that. Everybody was there. 12 doctors were there when I was operating. And I spent 15 man hours talking to 4 members of the family. So I've developed that compassion to treat, because Dr. Kalam has blessed me. He has given me a book called Compassion and Medicine by Dr. Schlim. Dr. the first Dalai Lama Rinpoche. So I actually fired my intern. I apologize publicly now, because I was upset because he is not treating the patient. So I was actually very angry. The reason is I'm so compassionate of history taking. The reason is something you'll find where, see, this is a true story happened 10 days back. The patient had an injury in Lucknow on 30th October. Patient is a child, 11-year-old. That 11-year-old brother was teasing the 6-year-old brother by telling, hey, what you hit me didn't pain me. So that fellow 3 times hit him. Fourth time, you know what he did? He took a scissors and threw on him. And the scissors went like that, opened scissors, and went through the lid, came out to the other side. And luckily, the doctor operated. And now the patient 20 days later contacted me. I posted for surgery. 15 minutes before the surgery, the anesthetist came. While talking, finally the patient told, I'm taking this tablet. Not a patient. The patient's father told, I got the tablet. Tablet भी गोली नहीं था. बोल रहा है कलर गोली. When they showed the photo of a tablet, then we saw it is an anti-epileptic drug. पूछा, बोल रहा है 7 साल ले रहा है. एंड देन क्या बोला, नहीं न्यूरोलॉजिस्ट दिया, क्यों दिया नहीं मालूम है. एंड देन अरे पहले ऑपरेशन कैसा किया, नहीं किया, हमको क्या मालूम है. And the patient had 25 relatives down, and in another half an hour I was catching a flight. Not half an hour, 3 hours later. So when I came down, I canceled the surgery and came. I thought there's a mob waiting to fight with me. I didn't, nobody came to me. But I'm seeing people came because of a child injured. Then they were all wondering, why did I cancel? Now we sent to a pediatric. Then that patient's relative is somehow a rough person. And he was angry that patients, what do you call, that a neurologist, pediatric neurologist doesn't know how to talk to me. I told him, should I do a police job or a doctor? So I said, I am a surgeon. I have 5 surgeries today. And then now you are telling me that you're not happy. You tell me now, should I operate or not? So for operation, I want you to be happy. If you're angry with the doctor, now if I have told you, if you develop epilepsy now again, that means fits, I have to send you to the pediatric neurologist. And if you don't like him, how will I operate? I said, come on, yaar. The doctor treatment अच्छा किया, diagnose किया, कैसा बात किया, I don't know. But I don't know the doctor. How can I teach him? And he's also a 15-year experienced doctor. So the problem is, I understand patient is stressed, the referral doctor is stressed, my nurse is stressed. But I was somehow, I don't know how, I was compassionate, cool. And then I told the man, okay, you tell me, are you cool down? Are you forgiving the doctor? I apologize. He said, no, no, doctor, you're a Padma Shri, you don't have. I said, come on, yaar, मैं क्या करेगा? I want to operate with peace. Because I want to repair the eye. And my touch wood, I went and spoke to my another patient who's after 7 surgeries, one surgery, I took the patient to Boston, and the whole cornea is white, and there's a membrane grown. So we have to do endoscopic surgery. And now I am the first endoscopic vitreous surgery in India with my friend Frank Kosh. Unfortunately, my endoscope broke. Now I have to buy one. So I hope some philanthropist will donate to me now, seeing this recording. And I hope this YouTube I'll send to these patients. My IT fellow and Divya nurse should send to all the trauma patients. Why I'm saying, and then I took the patient to Elvi Prasad. I don't have ego that I'm the only surgeon I can do. So I took the patient to Boston. Then I have now took the patient to Elvi Prasad in Hyderabad. And endoscopically, we have repaired the eye. And I'm happy. My first surgery, which I did in April with the 12 doctors standing with my 3D, the retina is doing well. And because of that base, now we will do one day keratoplasty. That means eye transplantation. And for that, we need eye donation. So that is why we need 3 lakh eyes in India every year. And we are only getting 50,000. So my Sundaram Natarajan Blind Free India, which is called Blind Free India Foundation.org or ksfin.org, I would like you to go through. The reason is a lot of people are suffering with blindness. One is I want to prevent. I want to work on artificial retina, gene therapy, stem cell, all this will not help trauma today. So one day it may help, but I want all this to be known to the doctors. So my teacher is Dr. Badrinath, who's no more. His teacher was Dr. Charles Keepens, who's the founder of, a father of modern retinal detachment surgery, who's the mecca of medicine in Boston, who told never say never again to a patient, whether a born blind patient or a patient who has undergone injury and blind. So same thing I tell, don't have a false hope. So it should not happen that that hospital in Singhani hospital was burned just because they could not save. He died not because of the doctor, he died because of the injury. Correct? So similarly, when the eye is smashed, you can't be blaming the referral doctor or the primary doctor or me. So I tell the patient, after operation, if you don't get vision, what are you going to do? Are you going to be angry? Are you going to be upset? Or are you going to cry? Or are you going to fight? As you correctly asked, the doctor should counsel. I know that none of the doctors have time, but we should create a team. If they don't, doctor doesn't have a counselor, his own secretary should do, or a counsel, or a receptionist, or a ward boy. So in my hospital, have you heard of that? Ramayana was written in Sanskrit by Valmiki in North, and in Tamil by Kamban. So we say Kamban was a weaver. In Kamban's house, even the weaving machine, which is a hand weaving machine, used to speak Ramayana. That means you touch that, it will speak. So in my hospital, everybody, right from the watchman, they know what is the retina and what is the injury and what should be done. And I am practicing for 40 years. So I hope through this question, I know I made a very elaborate answer. Um, People who are not have the problem will not take that, but I'm happy they're patiently listening, and I'm hope my listeners also are listening or future, because I think it's very important. I feel so much for the patients who undergo injury. That's why when I go to Kashmir, everybody knows me. And one day I jokingly tell the previous government gave me an award, I can win an election, but that's not my dream. Now, same thing I'm doing in Dharavi. So I'm creating thanks to one foundation, they are going to give me money. We are going to start a charitable trauma surgery center. So no patient should go blind, my father said, just because they don't have awareness. And I am telling you, no patient should go blind just because they don't have money. So everybody can, paying patient can afford me. But what about non-paying patient or a paying who can pay less, or a patient in Sion Hospital or JJ or Nayak? They can come to us now through my foundation. If the patient can pay little, we'll take that and we'll operate. If the patient can pay nothing, real patient, not just because they'll give me a ration card, but genuinely they cannot pay, we'll do free.
Uh,
I'm
Thank
sorry,
you so much.
I became emotional in answering.
No, no, you're actually the compassion that you spoke about it. It is actually seen through the cases that you are referring to. So many cases you actually remember. You
Yes, yes.
and
No, I
you could
remember.
elaborately talk about it.
No, you won't believe all my juniors have made notes and kept. I don't have any notes. So I remember surprisingly, God has given me like Swami Vivekananda, everything I remember. Only thing I don't remember the name of the patient, but I remember the injury. I remember how it
It
happened
is. Yes.
because everybody make a line diagram. I tell make a cartoon how the injury happened. Like yesterday, one child came from child name. He's a college going BCom student. He is working in he went to his father's bottle crushing factory. So I was joking with
Okay.
him. What is that bottle? He said, alcohol bottle. They empty bottle they bring. They crush it and give it back to something for re-making the glass. Something he told me. So I was just joking. Can you take the few drops and make one bottle and drink? No, 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 sir. I said, why do you go to the bottle crushing factory without a goggle? So I said, your father is the owner. He should be arrested because he has not made a protection for you. How can you enter a place where they are crushing? I hope the laborers are having a guard. Because everywhere, labor officer can find them and they can put behind bars. It's a law. So in India, small scale industry, they should have protective goggles if they are flying objects. And then if see, I have seen the supervisor just goes for 1 minute inside for something and gets injured, and that is why it is called a freak accident. But why should accident happen if you are mentally ready? That is why for every patient I know the history. Just now before this I got delayed coming to you because I was doing a Zoom meeting with my team to know about tomorrow's OPD patient. I go through the full history, which no doctor does. This came to my mind, and I made a SOP for that. I'm sorry with all my staff. I hope somebody is listening. I'm at least my IT head is listening. They get problem because I ask so many questions. And patient also one day, every patient yesterday, I got detachment. That is not your complaint here. Tell me what is your problem. Then the fellow tells bottle injury हो गया. अरे कैसा हो गया? Rush injury हो गया. कैसा हो गया? That bottle piece came and hit the eye. See, that many questions you have to ask. So the referral doctor also doesn't ask. The nurse doesn't ask. Or after asking all the question, something they'll miss. So I'll ask one relevant question. They'll give me all the answer.
Great to hear the case studies actually, and it is very interesting case studies as well.
Yes, yes. And
So,
actually, I have thousands of patients. So this reminds me, I think every patient I should give my voice and give a recording and put it in the YouTube so that anybody can learn from that. Want to prevent
yes, yes, yes.
and to say that even if it is bad, we can repair.
Even the surgical videos that you showed, it was very informative. I'm sure it will be helpful for the surgeons that are watching, future surgeons that are watching over here.
Yes.
So, with that, we reach the end of this webinar. Thank you so much, Dr. Natarajan, for your invaluable experience and enlightening us on the art and science of managing ophthalmic trauma. Your
Yes.
passion for the field and your dedication to advancing ophthalmology are truly inspiring. I would also like to thank our audience for their active participation and insightful questions. We hope this session has provided you with practical takeaways that you can incorporate into your clinical practice. As we continue to celebrate our 11th anniversary of Docplexus, we invite you to join us for our upcoming sessions. Uh, where we'll explore more topics of clinical significance. Thank you once again, and we look forward to seeing you in our future webinars. Stay safe
And
and take
if
care.
anybody has questions, either they can write to Docplexus and you can forward the questions by mail, or if whoever can make a note of my email ID, which was there in the last slide, but here I put again prof.drsn@gmail.com.
Do write to him if anybody has any questions. You can reach out to Docplexus as well if you have any questions.
Yes.
Thank you, sir. Thank you so much for the webinar.